Hi, everyone, and thank you so much for joining us for this second session on air pollution and cancer, where we'll be looking at policy change that we can help implement to bring down air pollution. My name's Rosie Tasker. I'm the Global Advocacy Manager here at UICC, and it's been my pleasure over the last 2.5 years to coordinate this project. And so, on behalf of the team, thank you so much for joining us today. Over the next hour or so, we're going to be hearing from a fantastic panel of speakers. And the focus of the session today is to really understand how we can translate data that we have on air pollution exposure and cancer into concrete policy change. And what are some of the practical policy entry points for organisations who are interested in this space? We're going to be diving a little bit more deeply into what's feasible for cancer organisations to get behind and how we can advocate in different national contexts. And we have a series of amazing speakers who will be able to run you through this, really with a view of helping to build your confidence on how we can start to have these conversations. So before we kick off with the really interesting part of the discussion, a few housekeeping pieces. This is going to be an interactive discussion. Everyone's equal partners in that. But we do ask that you remain on mute during the first half of the presentation. For those of you who have a question, and we'd really encourage questions from everyone, please do raise your hand during the Q&A, or you can add a comment into the chat and we'll try and raise that on your behalf. We will be sharing the report that we'll be talking about today, together with a recording of the session after the call. And over the course of the call, we'll be eliciting some of your feedback using Slido. So you can use the QR code that's on the screen now or the code. And through that, that'll take you through to Slido where you can share your perspectives. So today, we're going to be hearing from 5 excellent speakers. We'll be kicking off with Veronica Laneves, who's Head of Impact and Engagement at the George Institute for Global Health. And Veronica is one of the experts behind the policy report that we're going to be talking about today. She was also one of the reviewers for the evidence summary that we shared on Monday. We'll then be hearing from Dr. Hadi Mohammed Abu Rashid, who's the Scientific Advisor and Director of Programs at the Qatar Cancer Society. Dr. Samantha Pegararo, who's the Technical Officer for Air Quality Heat and Health Unit at WHO. Ms. Phoebe Ongadi, who's the Executive Director of KENCO, so that's the Kenyan Network of Cancer Organisations, and Dr. Urvashi Prasad, who's Director at the Centre for Air Pollution and Environmental Health based in India. So, as with most things at UICC, we wanted to kick off with you and your perspective. So our first question is, how confident are you feeling in your understanding of air pollution levels in your context? So that could be the city you're living in, the region, or the country. So we'll give you all a second or two to join Slido, and hopefully things will start coming through shortly. Wonderful. Okay, so starting to see some initial responses. People are feeling pretty confident. That's great to see. People are feeling really confident. That's even better. That means that we're going to be having a really rich discussion today. And it's also really interesting to see, given that this has often been seen as a slightly newer topic for the cancer community. Although that being said, we've been talking about this since about 1953, at least within a UICC perspective. But it's wonderful to see that level of confidence and engagement in the topic and in the conversation. So our next question to you all is going to be, what are the main sources of air pollution in your context? So again, that could be city, that could be region, or that could be country. We've put in a couple of suggestions that if there are others, then please feel free to select the other topic, or you can drop them into the chat themselves. And you can select more than one option as well if you'd like to, if you know that there's a bit of a mix where you're dialing in from. Fantastic. Okay, so we've got transport really leading the field at the moment, industry and power generation, waste burning, natural sources, agriculture, and household energy, really kind of out in the front. That's really interesting and also really helpful for our panel as well, as we're talking about different policy options that we have available to us. But also that generally pretty closely corresponds with quite a lot of the data that we've been seeing within some of the cancer studies that we looked at for the evidence summary report as well. So that's fantastic. And then the final question to you all is, are there air quality targets wherever you're dialing in from? And if there are, do you know what scale they're at? Fantastic. So we've got a couple of situations where there are national targets, a couple of situations where there's no formal, and a few people who aren't sure. But that's great because that gives us a fantastic starting point for the conversation today. Amazing. Wonderful. Well, in which case, it's my great pleasure to now hand over to Veronica to run us through the headlines from the report. So, Veronica, it would be great if you could give us an overview of what the key findings were and what it is that you think would be most important and interesting for the cancer community to know. Thanks so much. Over to you.
Yeah, thank you, Rosie, and hello, everyone. It's a great pleasure to be here and to join you on this call today. So as Rosie mentioned, I'm the co-director of Impact and Engagement at the George Institute for Global Health, and my role really focuses on translating evidence into policy and practice. So this is really, what we do on a daily basis. My background is in environmental policy. I've worked in environmental policy for a long time, and particularly in climate policy. I have a bachelor and a master's degree in environmental science. And I've also worked at the interface with health for a number of years as well. I think this is a really interesting piece of work. I wanted to really share with you three key messages from the report today to frame your discussion and help to introduce the discussion that the panelists are going to have. And the first one was that air pollution is really an under-recognised risk factor for cancer. So I think what this work really highlighted to me was that while it's broadly understood to be bad for health, particularly for respiratory conditions, there is not yet strong recognition in the general community of its link to cancer. And the evidence synthesis found that air pollution substantially increases the risk of developing and dying from a range of cancers. While we might have an intuitive understanding of the link between air pollution and lung cancer, for example, the research also shows elevated risk for brain, kidney, stomach, and other cancers as well. So it's really a systemic risk factor. So I think there's a really key role here for cancer advocates to highlight these links and to build that understanding with policymakers and with the broader community. And that in turn supports the momentum for change. So really translating that evidence into policy and practice. And that will position you well to shape this conversation and build that understanding that's really needed to support greater action. The second key message I wanted to share with you is that, as Rosie mentioned, air pollution interventions have been around for a very long time. And so policy solutions exist and have a strong track record. In my own state of New South Wales here in Australia, we've been doing air pollution control for more than 75 years, and we're certainly not alone. There's a great body of evidence here about what policy interventions are successful in different circumstances. And so the report presents a series of case studies that we looked at from local level interventions up to national level frameworks. And these address both point source pollution, like industrial smokestacks and power generation, as well as more diffuse sources like vehicle emissions. And the right approach really depends on the sources of pollution, the specific pollutants of concern in a given location, the cost of implementation, and the level of political support for change. So all of those things come into play in determining what menu of policy interventions you might choose in your particular context. And the third key message I wanted to share was that monitoring and standards are the essential foundation for any policy action. There's a number of policy interventions that can be taken, but they all require these two fundamental building blocks. And the reason for that is that air quality is not uniform. It changes minute by minute and is affected by seasonal factors like crop residue burning and varies with climate and geography as well. So solutions really need to be tailored to the specific locations and must take into account the local pollution sources in the surrounding environment. And without robust air quality monitoring, there's no evidence of what air quality levels are or how they change over time. And in those circumstances, policy action is at best trial and error. Air quality monitoring measures the concentration of different pollutants and compares them to established standards. And so it's impossible to assess whether standards are being met if they don't exist in the first place. So the key point here is really that standards and monitoring go together. They're two sides of the same coin, and they're fundamental building blocks of any serious effort to improve air quality and a critical starting point for advocates to prioritise. So those are, I think, the key standout points from the report. I think air pollution is a preventable cancer risk with proven solutions. And so you can argue for solutions that have been tried and tested in other locations, and that builds momentum for change. By working with other organisations, you can amplify your efforts and draw on a long history of policy action, ensuring that air quality monitoring and standards are in place. And by doing these things, I think you can have a meaningful impact on policymakers and really support greater action in this field. Thanks, Rosie.
Amazing. Thank you so much, Veronica. That's really kind. And I really appreciated the points you were making around kind of reflecting on kind of what could happen next. Um, I want to ask a question as someone who, recognizing the vast majority of people on the call at the moment are from within the cancer community, as someone who has a slightly different perspective. In doing the research, in writing the reports, do you have any reflections on where the cancer community could support or add value to influence policy development and implementation? Is there anything that kind of jumped out to you that maybe we don't think about?
Yeah, I think the cancer community can potentially learn from some of the climate advocacy. So one thing that climate advocates have done is really point out the cost of inaction on climate. And I think, the links with cancer are quite frightening when you read them. I think they are impactful to policymakers and to the general community. And so I think highlighting that and building that understanding makes the case on the cost of inaction. And I think that's a very powerful thing.
Fantastic. Thank you so much for that. And I think what I might do next is then open it up to the rest of our panel because we have so much wonderful expertise here. Um, and I think maybe I might, talking about the kind of cost of action and the cost of inaction, I might pick on Dr. Samantha Pecoraro from WHO first. Sorry, Sam. Because I think it would be really interesting to understand, given how long WHO has been working on the topic, how can governments prioritize clean air interventions, building on existing commitments and good practices, and are there any kind of within that economic arguments picking up on the point that Veronica made.
Thank you very much, Rosie, and good morning or good afternoon to everybody. So it's a pleasure to be here, and thank you very much for the invitation. But I think the point that Veronica was making is really important. I think the latest evidence on the global health cost from air pollution rise up to 8 trillion. It's an estimate from the World Bank. But this does take into account the overall health system burden, and would be indeed really interesting from a policy perspective also when talking about national cancer control plans to include indeed some cost estimates on specifically on cancer. But to take this more broadly, what countries can do, reiterating what was mentioned before, one of the pillars of our work in WHO is the development of the WHO Global Air Quality Guidelines, the latest one being published in 2021 and provides the levels and recommendations for different so-called classic pollutants, the different levels that a priori would protect from public health, because the evidence from the scientific community is that there is no threshold. Talking about a non-communicable disease, this is very similar to the alcohol. That what is the intake of alcohol we can take? Scientifically, it's zero. And this is the same with air quality. So building from those guidelines that provide levels from particulate matter and other air pollutants, countries are invited to develop standards. The guidelines are a product that has no legal binding for countries, while standards do have. And therefore, the importance to work on standards that aligns as much as possible to WHO air quality guidelines and their interim targets. So this is one of the first things, the monitoring. Just to provide a data, WHO has a database of air quality monitorings from which it derives the levels of air pollutant to then calculate the burden of disease. And 68% of the air quality monitorings and measurements are coming from high-income countries, while only 6% is present in low and middle-income countries. So there is a matter of also inequities, if you want, at the global level in how measurements can serve, and also the calculation of the burden of disease. On the positive side, there are many international opportunities to then bring countries together and fostering the action on clean air. Last year in Colombia, WHO hosted, in collaboration and co-organization with the government of Colombia, the second global conference on air pollution and health. Concluding with a strong political and financial commitments from over 50 countries, cities, organizations, also non-state actors like UICC, and shared a global goal of reducing by 50% the health impacts from air pollution by 2040, which was then adopted as a global target at the 2025 78th, I would say, World Health Assembly. So this is the way at the international level that there is mechanism through which indeed the collaboration between countries and pushing for the agenda for clean air for health is being held.
Fantastic. Thank you so much for that, Sam. That's wonderful. And I think there are two pieces that I wanted to bring out from the conversation that we had on Monday. The first was there was one of our speakers, Letitia, from the American Cancer Society. When we were talking about there being no safe level of air pollution exposure, she presented very briefly a study that they've been doing in the US where they looked at exposure to air pollution amongst children and the impact it had on childhood cancer mortality risks, and found that actually the 5 microgram per meter cubed of PM2.5s was really critical, because actually above that threshold, they saw significant increases in childhood cancer mortality. And so we with the help of the George Institute, have tried to position the air quality guidelines as a key resource for the cancer community. Really encourage everyone to go and check them out. I think the other piece that we've seen more recently as well is a report from the UN Special Rapporteur on the right to a healthy environment, who really clearly states that actually legally states have an obligation to protect their populations from air pollution. And again, that's resumed in the forthcoming report. So I'll leave that trail there. But I know this is a newer area for certain cancer organisations. So I want to turn now, if I can, to Dr. Hadi. And kind of, Dr. Hadi, can you tell me a little bit about what helped the Qatar Cancer Society begin framing air pollution as part of cancer prevention and control? And how have you kind of moved into the space?
Thank you so much, Rosie, and thank you for this timely, important discussion. So at the Qatar Cancer Society, it started with the more and more we are adapting that cancer has risk factors, multifactorial risk factors, and we really want to work on the cancer risk reduction and cancer better care. We need to tackle all the factors, and more evidence has been shown up that the role of air pollution impact on the as a risk for cancer, not only lung cancer, but other cancer has been mentioned. And also how that, as you mentioned, Rosie, and the study that you referenced in the pediatric childhood cancer, the mortality, how the air pollution, not only as a risk factor, but also impact the mortality of people living with cancer already and increase their mortality. So that's and also because of the national policy, here in state of Qatar, there has been a lot of interest in climate change and air pollution, and combining all of that put Qatar Cancer Society on the track of really being more involved in the topic of air pollution. And then you guys came, as you mentioned, Rosie, almost 2 years, 3 years. I think the discussion happened even 3 years. It go back before that we started having let's do a collaboration on to understand more air pollution, having multi-stake and the UICC approach of having representative from the regions to understand the mapping out the air pollution impact on all the worldwide, and to work with academia and all of that, and we start to find out that there's really a gap in the understanding and how people are looking at I mean, we don't want to be, air quality technical entities. We are a cancer organization. We want to put out the topic of air pollution as it's a cancer health problem. It's the concept of cancer problem, health problem, equity problem, and that's why we became very involved, and I've been personally involved in this, and I think that involvement, the UICC. Brought the discussion not only for the Qatar Cancer Society, also for the region. We've been discussing this more and more at the level of the national cancer strategies of how we build more partnership, more equity, more and connecting clean air to prevention and health at the policy dialogue level.
Fantastic. Thank you so much for that, Dr. Hadi. And I think we'll come back to you as well, because I know that there's a huge depth of expertise within the Qatar Cancer Society on the topic. But I also wanted to turn next to Dr. Rivashi. And Dr. Rivashi, you've founded an organization focused on air pollution and environmental health. So could you tell us a little bit more about your journey into this space and what's been motivating you and what's been your experience so far?
Firstly, thanks a lot, Rosie, for having me here, and pleasure to be here with this entire panel. So interestingly, my entry point into this was not with cancer. I trained as a public health specialist, and I spent years working on public policy at the highest levels in the Indian government with the Indian government's Apex policy think tank. And my work was there about how evidence moves or doesn't move from research into government decision making. And what I observed repeatedly was that air pollution was generating a substantial amount of scientific output. We had data even from our own research agencies to say that we were having in the tune of close to 2 million premature deaths every year due to air pollution. So it was not that the evidence or the data was totally absent, but there wasn't enough policy traction. The translation of that evidence into policy was that problem. And that cancer dimension came into sharp focus quite quickly in my own life in a personal way. I live in Delhi, and I have lived here for a large part of my adult life. And this is not an abstract context because Delhi has repeatedly recorded the worst air quality of any capital city in the world. And you feel it, you can see it. And when I was diagnosed with what is called a non smoker's lung cancer 4 years back, ALK positive, which is an oncogene driven lung cancer, where air pollution is actually considered to be a very important factor. And there is already evidence, and evidence that's only increasing to show that it is a big factor in people like me who are young, who've otherwise been very fit, very healthy all our lives, and we end up getting such a diagnosis. So when I then sort of moved on from the policy institution, I decided to set up the Center for Air Pollution and Environmental Health, which you were referring to, which is not just to produce more research, but really to be the institution that can sit between the evidence and the policy and make that connection, which somehow neither the scientists nor the bureaucrats have had the time or the mandate to make themselves. When I look at India's policy architecture, we do have a national cancer control program. We also have a national clean air program. We do have air quality targets at the national level as well, city-wise targets. But I don't see that formal engagement so far between these two programs. The health ministry and the environment ministry are sort of operating in parallel universes. And uh, cancer organizations in India, they are largely focused, and not wrongly so, on treatment, on screening, on awareness of lifestyle risk factors like tobacco and diet. But the idea that the air itself can be a carcinogen is what demands urgent policy action, and that has simply not entered the mainstream cancer control conversation in our country. And that gap between what the science says and what the cancer policy does is what keeps me in this work, because the implication is not small. If PM 2.5 is a group 1 carcinogen, and if hundreds of millions of people are breathing air that exceeds safe limits every single day, then cancer control that doesn't engage with clean air policy is by definition incomplete. It's not wrong, but it's incomplete. And I think cancer organizations globally, very much like UICC, they're extraordinarily well placed to close that gap if we all choose to step into it together. And that's what sparked my interest, and that's why I'm here today. Thank you.
Fantastic. Thank you so much, Dr. Vashi. And thank you for issuing us the challenge as well of getting more involved. I think that's really great to have that kind of also invitation to get more involved. And I think so for me, there's a couple of themes that have emerged so far, and I want to present a couple of questions to the whole panel. I think maybe the first one to Dr. Avashi's point is around how is it that we can build connections between universes, as you said. And I think there are sort of two subsets within this. What has worked or not worked when we've been trying to engage communities on clean air. And what's worked or not worked when we've been trying to engage policymakers, recognizing that our policymakers have to listen to communities, but often they're slightly different but related processes. I realize that's a very easy question for everybody to answer, so I'm sure everyone will leap at the opportunity to do so. But I wanted to check, see if anyone has any thoughts. So how is it as cancer organizations we can start this process by better engaging the communities around it, to the point that Dr. Ravashi made, that the air itself can be a carcinogen? And if anyone has any thoughts, please, to my panel, jump in.
Uh, if I may, what I think, I mean, which is what has been mentioned and even mentioned in the chat, using simple messages, clear, direct quote, and when you say what's more powerful than air becoming carcinogen. So this is when you make it simple, when you frame it in a connected to health, and when it's coming from trusted messengers. I mean, you need simple messages, frame it properly, connected to the health, coming from trusted messenger entities and evidence-based, and then link all of that to the to daily life. And this is not only impact the community, but also when you translate the impact on daily life to data and numbers, policymakers will listen, because at the end of the day, if you impact the daily life of the community, then you're impacting the people that they put the policymakers in their seat. So this is how usually at the community aspect it work. And I think from the case study that in the report, I really like the I know that my colleague from Kenya will go over it, but I like this whole the promote connection between the community aspect, the media, and lived experiences. So those are the really, and then going back to the case from Wales, connecting the data, transferring data to policies. Those two cases really can be guide cancer organization on how to work with the community and how to work with the policymakers. Back to you.
Fantastic. Thank you so much, Dr. Hadi. And Dr. Ravashi, over to you.
Yeah, I think just carrying forward from Dr. Hadi's point, I think what we're also talking about a lot here in India, what we're also partly trying to do, but I think that's where organizations can play a big role, organizations working in the cancer care space as well. I think making it really very tangible for people, that what can this mean for my life, and why should I care about this? And eventually building up a momentum which makes it impossible for the politicians to keep, sort of pulling wool over people's eyes, or standing up in parliament and saying, well, there's no direct link between air pollution and disease or death. And we have heard that in parliament, sometimes from politicians, very senior ones, from health ministers. So I just feel that if we can create that kind of mobilization of people, where it really becomes impossible for anybody to come and say that, well, this is not a big enough issue, I think then we can achieve a lot of success, because we know a lot of the policy measures. It's not that we don't know them, but that will to implement will come when we get that mass mobilization around this issue. So I think for that, we need to make it very tangible. What's in it for me? What's in it for my children? Why should I care? Why does it matter to me?
Fantastic. Thanks so much, Dr. Ravashi. Veronica, over to you. I think you're up next.
Yeah, thanks, Rosie, and I agree with everything that's been said so far. I think that highlighting that lived experience of people who have had cancers like yours, Dr. Ravashi, non-smoking lung cancer, for example. I mean, there's been many media stories about those types of cancers becoming more, and that's alarming to people, and I think it's very difficult for policymakers to look someone in the eye and say, well, your cancer wasn't caused by air pollution, when they're sitting in front of them showing them the disease that they're suffering from. Excuse me. So I think that's really powerful. Also, connecting it to real action, I think. So being able to say, look, this is the problem, you can't ignore it, but also there are solutions. Lots of people have done it before. It's feasible, it's implementable. We're just waiting for you to act. So, really driving home that point that the solutions exist.
Fantastic. Thank you so much, Veronica. And Sam, over to you.
Yeah, thanks. Just to add again on my side on to all that has been said, I was thinking also on the power of connecting with other health associations, other health topics, and with other health determining sectors, like as cancer organizations, you have connections with the cardiovascular community, the respiratory community. So acting all together in demanding for action can add on the power of the health voice, no, behind the demand for cleaner action. And I mean, of course, I think we were talking more about in our own settings what we can do, but I'm just bringing an example of something that I think it was a very successful exercise at a global scale, which was the call for cleaner action that was launched before this global conference I was mentioning before, and which was signed by millions, like over almost, 50 million signatures from many different organizations representing patients, representing health workers, and that creates the demand and propose the concrete actions from both what do we want policymakers to do, and also what do we commit as health societies, health associations, health community to continue working on, and this led to creating the demand, no, and reinforcing this duty for governments to act, which then built on the commitments that were launched by countries and cities and organizations at the conference. So I think this can add as an action point from cancer societies in general. Over.
Fantastic. Thank you so much for that, Sam. That's wonderful. And I think it also picks up on a couple of points that we're all probably more familiar with. I think a lot of the progress we've seen in tobacco control, which is obviously a much more localized air pollutant. We've achieved that by working with other health groups to try and kind of push that policy agenda forward, and also significantly improve the understanding of the general public about the risk. Unfortunately, Phoebe isn't able to join us today, but by trying to sort of some way highlight the work that Kenko has been doing, the team has been collaborating with a number of other organizations to precisely do this, kind of build awareness amongst communities. Nancy, I think you're from Kenko as well. Can I hand over to you?
Yeah, thank you. Thank you, guys. I'm from Kenco. My name is Nancy Mweni Musyoka, joining in to represent Phoebe, but she'll be joining in a few. She's just off from another meeting. So maybe I'll allow you to go ahead and present a few, but I'll allow her to join in.
Wonderful. And actually, Phoebe seems to be arriving just now.
Yes, just on time.
Wonderful. And so thank you so much, Phoebe, for joining us. Your timing is impeccable. Just while you get yourself settled, one other example of collaborating with other groups that we've seen has been the Rue Scolaire campaign in France, which has really been focused on trying to protect children from air pollution by banning traffic around school environments. And I think that's quite a really nice tangible example of kind of how different cancer organizations are partnering with child health groups, with environmental groups, and with other NCD organizations to try and drive change. But Phoebe, I'll hand over to you. And the question we were asking was actually, what's worked or not worked when engaging with communities on clean air to help us try and drive some policy change. And thank you so much for joining us.
Thank you very much. I'm so sorry for joining late. I was having trouble with joining in. Yeah, so for us, what has really worked is the data. And I must say that for us in Kenya and KENCO, air pollution and its a connection to cancer is new. So it is an area that we are currently actively spreading awareness of. So what has really worked is the member organizations, because KENCO has over 80 member organizations. There are some of them who are already working on matters air pollution. So what worked was the statistics that was both shared nationally and globally. What has also worked for us is leveraging on the media, the local media. These are the local radio stations, the print media, the television. And in our country, we have over 47 counties. And in each one of those counties, there are different dialects that they speak. So those dialects are able to reach out to people from the community level. As you know, that communities are the linkages between policy and innovation, policy and practice. So as we do those awareness to the grassroots, using the radio stations, sharing the stories, especially the rising cases of not only cancer, but also respiratory diseases. So what has sort of not worked is the complexity in some of these terminologies, and also what has also not worked is the lack of there is very low awareness around air pollution and air pollution linked to cancer, and also the complexities around the terms. So that is basically what has worked and what has not worked for us. Thank you.
Wonderful. Thank you so much for that, Phoebe. And I think the work that Phoebe's organisation KENCO has been doing is also in the policy reports. We can dive a little deeper there, but it's a fantastic example, particularly, as you were saying, in terms of using those media channels to get the messages out in local languages. So it reduces the barrier to accessing that information so much more. I think we had two hands up, so I'll come to Vandana next, and I think Nashwa, you had a hand. Oh, can I come to Nashwa first? Because I think you've had your hand up for longer. Nashwa, over to you.
Yes, hello everyone, and I'm really happy to join this meeting and this dialogue and listen to all the thoughts, the great thoughts that you have said. I would like to share our experience in Shifal Urman Hospital in Luxor, Egypt, and what we have done for air pollution, and that we have taken measures to protecting the environment as well, not only the patient, but also the environment surrounding us. What we have made until now is that we have installed the solar energy system that currently covers 54% of our electricity consumption from renewable resources and contributing to a reduction of more than 1,000 tons of carbon dioxide emissions annually. And then in parallel, our broader environmental strategy has reduced electricity consumption by 18.9% and water consumption by 14% and generated significant cost saving over 1.2 million AGP annually from solar energy alone. And these are not just the environmental gains, but we have also direct public health interventions. We have reduced emissions at this scale, and we also converting the hospital cars to use the natural gas instead of diesel. And also we went to the schools in Luxor, all the schools there to in the lung cancer awareness months to make trees in these plants in these schools, and these are direct public health interventions. We also have a tobacco cessation clinic at the hospital, so for those who want to, and for relatives as well of the cancer patients at the hospital who want to cease smoking, and all of these are strongly linked to the lowering the exposure to air pollutants such as particulate matter and nitrogen oxide. So our experience showed that the hospital can move from being contributors to air pollution to becoming part of the solution if the right policies are in place. Thank you so much for your time.
That's fantastic. Thank you so much for sharing that, Nashwa. And if it's okay, I might connect you up with a member of the UICC comms team, because I think it's so wonderful to be able to capture some of those. And I love the point you were making around hospitals being part of solutions and being from emitters of air pollution to a mechanism to help reduce it. Vandana, over to you.
Thank you, Rosie, and thank you to all the speakers. Wonderful insights. I'm here representing Lung Connect India Foundation, and I first of all want to thank Urvashi, who's a friend, for highlighting the abysmal and the dismal, the air quality in India. As a part of one of the largest support groups, lung cancer support groups in India and Southeast Asia, we are concentrating. We are one of our core objectives this year is highlighting the direct effect of air quality on lung cancer. We are also trying to bring to project the real world data in terms of a lot of younger patients, non-smokers, who are a part of Lung Connect India Foundation. Through them, we are trying to highlight how they're all non-smokers, and we have a 22-year-old, we have a 25-year-old, we have a 28-year-old who've been diagnosed with stage 4 lung cancer, and they're all non-smokers. So what is going inside their lungs? So when the air that they breathe becomes a risk to their lives, it is important that patient organizations like ours work towards highlighting this as a major risk for lung cancer, and also the efforts are on to reach out to the policymakers through lived exam, through stories of people who are living with the disease, because they have a lot of questions. They want to know why they got the disease. And that is something that we are doing. And it is also very important that advocacy organizations across the world make this as a part of the agenda. Like Urvashi said, and the other speakers also said, there are lifestyle factors that affect why somebody gets diagnosed with cancer. But what about those who have, no vices, who are just leading normal lives? Why do they get cancer? And since India is, I think, right on top when it comes to particulate matter 2.5 and the air quality being so poor, it is important that as a community in India and also as a global community, we start talking more about it. And I like the inputs given by a lot of our wonderful speakers here. And the effort is to raise better awareness about the air quality and its direct effect on lung cancer.
Thank you so much, Vandana. I think it's really fascinating to hear the work that you're doing around that. And I think also the point you make around kind of costs of inaction, and that comes back to the point that Veronica was making. Often with costs of inaction, we talk about economics, but I think the rise of lung cancer cases in young adults and in never smokers are a really tangible, really hard to deny cost of government inaction on air pollution. And I think we're seeing, as the data develops on other cancer sites as well, be able to make that cost of inaction case even stronger. Ritu, over to you.
Can you hear me?
Yes, we can. Loud and clear. Go ahead.
Okay. Hi. Happy evening, and thanks to all the speakers for all the inputs given so far. I'm a founder of Highways Infinite, which is the only organization which travels across India from remote rural to urban setup with cancer awareness workshops. And this also includes preventive and protective measures during the campaigns. While we talk a lot about tobacco and all, because we have like photos and something to show, and this thing, as far as air pollution goes, we sort of talk about air pollution just like that, without any you can say props, or without any gazettes or posters or something like that. So, and policy making will be taking a lot of time, as we all are aware of it. So meanwhile, I was wondering if there are any, it's open to all, if there are anything which you think we should include, like photos or some videos, or some animations to just talk about air pollution also, because we can't do it for hours. It has to be like 2-3 minutes, 4 minutes type the way we do for tobacco and other things. Thank you.
Fantastic. Thank you so much, Ritu. I might
I
come
hope
to
I was not very fast talking.
That was perfect. I might come to Phoebe first, if that's okay, given
Sure,
your
sure.
experience with kind of community outreach. Do you have any
Yeah.
thoughts on?
Yes, please come up again.
Yeah, of course.
Okay, so Phoebe, my question was, when you do community awareness on cancer, like that is what I do across India and across, across the literacy barriers, language barriers, geographical barriers, socioeconomical barriers. So we do talk also about protective and preventive measures, in which majorly we do talk about tobacco and other risk factors, which can sort of increase the risk for any cancer. I do mention a bit just about air pollution, but I don't have any, very interesting or something adapting photos or something which will leave a mark on the people communities with whom I'm talking, as far as the air pollution is concerned. So my question to you is, do you have anything what you are doing in your country like this?
Thank you very much. And as I mentioned earlier, one of the challenges is really trying to break down the air pollution message, especially in the lower and middle income countries. So again, as I mentioned, what has also helped us is to link that to prevention messaging. So we link the risk factor of air pollution into cancer prevention messaging. For example, we tell them easily if the link between exposure to polluted air and to developing eventually lung cancer. And what has really helped us work out is now bringing in the lived experience. And the lived experience, persons living with lung cancer, persons living with cancer, and then they will say that at some point I was exposed to the fuel, I was living near the hospital incinerator, there was no clear disposal of such. So then when you link it to real life experience, especially in communities like India, like Kenya, where you talk to people at the grassroots level, link it to real life experience. And how you link it to real life experience, bring in the people who have gone through it, and now they talk to them on a peer-to-peer. They say, I was exposed to this for such a period of time, and I got this respiratory disease, I got this cancer coming up, so then that can help you. And then, of course, also, you can also try, especially amplifying the community health voices. I don't know if you have them, but in Kenya, we have been using the community health promoters. So we amplify the voices of the community health promoters because they are the ones who are at the grassroots level. They reach the patients easier. They are able to do the campaigns easier. They are present during the prevention and screening programs. They are present doing that. So then that linkage using the community health promoters, speaking in a language that these people can understand, and then linking this risk factor to real life experience is one of the ways that can as well work. Thank you.
Fantastic.
Thank you,
Thank
Phoebe.
you so much, Phoebe. Dr. Hadi, you also have your hand up. Over to you.
So thank you so much for this very important question about developing materials and content that match your need. So regarding so our experience, one of the, which is I think it's always when you don't reinvent the wheel. I believe in this 100%. Map out your partner that they work on the same topic and benefit from them. So one of the very important partners here in let's say in the Gulf region, there are so many industrial hygienists, health and safety, and they have fantastic material on awareness on how you should about the whole concept of air pollution, how you should adhere to occupational safety, how you need to adhere to PPE, which is, how do you, every region is different. So in our region here, the whole indoor exposure is not an issue. Indoor fuel and all of that, that's not a problem. So my recommendation is, you can. It depends on the area where you're focusing on. If you are focusing on industrial area, you cannot target everyone. You have to believe this. So pick your biggest priority population, because you can define a population, work with them. If your area is more industrial, work with your industrial hygienist. They have a material that should be fantastic, simple pictures, images, and all of that. If you are area that is more the sources Indoor fuel, I will say work with your municipality. Municipality always, they have this information that it's simple. All municipality, they have to have some kind of information about the whole indoor fuel use. So just map out your partner and look the messages that is already exist, and build on other community. If you have a system, community health worker like they have in Kenya, because that system is already exists in Kenya, and Kenko did amazing job built on it. So think what you have and build on it. Back to you.
Thank you.
Fantastic. Thank you, Dr. Hadi. Rishi, you have a huge response. Sam, over to you.
In light of time, sorry, just to add a couple of products that may be relevant for this question, which I think is very important, and also very important the point that Dr. Hadi was making on mapping, the target audience, the stakeholders, and the need behind, the message that you want to convey. The first one is a WHO product that is a training toolkit for health workers that addresses air pollution, explaining what air pollution is, what household air pollution, ambient air pollution, the general health effects. There is content, of course, also on cancer, and what is the role of the health workers and the health community, let's say, in conveying messages. And here, you may find some examples that need to be adapted, again, as we were saying before, to your needs. And then there is a nice initiative from Clean Air Africa and the University of Liverpool, which is also a WHO collaborating center. And they developed job aids with visuals and pictures specifically for community health workers to then go to the households and explain what household air pollution specifically is and what are the preventive measures to be taken. It is not on cancer specifically, it's on the overall health burden from household air pollution. But I will put the link in the chat because I think this may be an example that, of course, with the given adaptation may be useful to think about. And also to mention that to the best of my knowledge, this was pilot tested and disseminated in Kenya in all the 47 counties and included as part of the formal training of community health workers. And here, like my last point on including air pollution and environmental risk factor in general as part of the training curricula and the education of the health workers in general. I think on the Cancer Society have a role also on that regard in leveraging this argument for the inclusion of environmental risk factor in the education. Over.
Fantastic. Thank you so much, Sam. And I will also, if you drop the links in, I will also send it out with the thank you email to everyone who's registered as well. I'm going to come to Veronica next, but then I'm going to come to the whole panel with a final wrap-up question, and that's going to be what's one realistic first step a cancer organisation can take to engage in clean air, even with limited capacity? It sounds like there's an awful lot of interest, so it would be wonderful to get those thoughts from the panel. So I'll leave that with you and I'll come across to Veronica for her response.
Yes, thanks, Rosie. Just very briefly on engaging with communities, I just wanted to say that I think important to also present them with the action that you're proposing to take, because I think with air pollution, because it's not caused by individual action, that can be quite disempowering for people to hear that, this is a significant risk factor unless we have sort of clear actions we can take to address that. Just on your question, I think what cancer organisations can do more than anything is really disseminate the information about air pollution being carcinogenic, being a significant cause of cancer, and really raising awareness of that issue. So thank you, Rosie.
Fantastic. Thanks so much, Veronica. And I'm going to go around my screen and I will come to Phoebe next. Phoebe, what's your one recommendation?
Thank you very much, Rosie. And as I'd mentioned, talking about our cancer organization, we are a policy-driving organization. So one of the ways that we can use this is to we strengthen advocacy for prevention as a prevention forecast policy. So then we are like framing clean air in as a cancer control strategy. Then it can help to drive strategy. So this can be enforced by the case of investments in clean energy. It can help us invest on waste management. It can help us invest on urban planning by looking at it as a prevention forecast policy. Our country right now, cancer is the #2 leading cause of death, wiping away so many people, and driving that as a strong prevention strategy can work. And then what can also work is using data as an evidence of health perspective. We know we do a lot of data-driven advocacy. We get to parliament, we get to government, they get to hear us when we present data. Then now cancer organizations can leverage on data and strengthen that, having the exposure data with the outcomes, mapping around people who live around waste disposal areas. For example, we have a very big dump site. That area we can do studies on some of the diseases that go there. We have the type of foods that are used in the rural areas. So then data. And of course, finally, and I stress this, using the survivor and community voices. Those are the people that are trusted most. They get to hear most. They get to demystify some of the complex information. Where policy and systems are complex, the communities and the organizations are simpler. So then leveraging them, the community, giving the survivors information. And when we do that, we amplify those voices and we help to elevate the demand around that. And also we help to drive the health advocacy in a language that the policymakers cannot ignore.
Phoebe, I wish I could bottle you. That was a fantastic response. Thank you so much. I'm going to come next to Dr. Hadi, if I may.
So I'm just gonna make it realistic because we have a different cancer organization, different abilities. My advice is just go identify one partners that they are already working on quality, air quality and air pollution in your area, in your country, in your context. Then choose one message or one policy entry point. It depends on the level of the organization. Are they focusing on the dissemination, the awareness, or they are focusing on the policies and action? And this choose one, and actually, if you do all of, those three together, this is more than enough to way it start. One partner, one policy entry point, and one message based on, which is evidence-based message, data-driven message, not just. This is one of the things that you need to build it, and this is stressing on the point that Veronica mentioned, that it need to be based on important, trusted information. Back to you.
Fantastic. Thank you so much. Sam, I might come to you next.
Thanks. I think all the great panelists already addressed many of the key points. Maybe so, just like, don't let anybody tell you that this is not your own business, right? Because clean air is everyone's business, and most of all, a health business. So good luck and good work.
Wonderful. Thank you so much for that. And Dr. Vashi, over to you.
Yeah, I would say that, because again, I'm coming from a very large continental size country, so I think I speak more from my context, but I think it would apply to many other contexts too, which is that really getting that very granular, localized data. So in India, what we're trying to answer, or rather, I'm trying to look at through my work, is, do our highest burden districts or catchments actually correspond to areas with poor air quality? And even if we don't have perfect cancer registry data or hospital records, I think that is something that as cancer organizations we could bring together, because that produces something very powerful, a locally specific evidence base that connects your existing mandate to the clean air agenda. And I think once that is there, then you have a reason to be in the room with the environment ministries, reason for funders to support your engagement, and everything else follows. So I think we do have a lot of data, but it might be scattered, there might be overlaps, or we might not have necessarily put it together in a way where we can very clearly make the case that, here we are seeing high burden of respiratory diseases or cancers or whatever that is. And these are also areas which, by the way, happen to correspond with very poor air quality. So I think if we can start with that, and then also something that I have tried to do is to, since you mentioned young adults, is to really highlight how lung cancer driven by air pollution is actually showing up disproportionately in younger people and younger women. So there's also a gender differential there. And I've tried to do a survey of clinicians in India to say this. Because I think that also, in a way, is a quick way to kind of overcome that data doubt that a lot of policymakers have. Because if I can get 100 oncologists to say that, this is a problem, we are seeing this, going up, it becomes much harder for people to sort of refuse. Because I think if it's just one or two of us being there in the room, I often get told, well, you're the odd one out. And I keep telling them, trust me, I'm not the odd one out. And so I think getting the clinician voices there as well, people who see this day in and day out in their clinics, in their practices. And secondly, I would say just clearing up those data gaps, those overlaps, and really making a very tight case that where you have poor air quality, you do have some of your highest burden of disease areas too. So I think those are, two of the points I would make.
Fantastic. Thank you, Dr. Ravashi. And thank you to everyone for bearing with us. I realize we are over time, and I cannot do anywhere near justice to the conversation that we've had today. So I think for me, the main things are that we're starting from a much more robust data foundation than I think we often recognize. There is loads of data out there. It may be held by partner organizations. So we need to sort of build those collaborations. We have such a strong and robust foundation of policy recommendations, and huge thanks to colleagues at the WHO for developing those. We have government engagement. Governments have agreed to try and cut air pollution related mortality by 50% by 2040. So we do have a window of opportunity for that policy work. And we know so severely the costs of inaction, as Avashi was saying, around the impact it's having on people around the world. So from here on in, I just wanted to say a huge thank you to our panelists today. You have been absolutely wonderful. A huge thank you to the UICC Task Force on Air Pollution and Cancer, who've made the report possible, together with the excellent team at the George Institute. UICC will be continuing to explore its work on air pollution as part of our lung cancer programme. And so I just want to say there's a few questions still open on the Slido. One of them is, what action would you like to take? If you can tell us that, then that'll help us shape whatever it is we want to do next. And we're really building our air pollution work around the needs and priorities of our member organisations. So if you can tell us what's important to you, then we will do our best to try and respond to that. And it just leaves me to thank you all for all of your participation today. We'll be following up with the resources that everybody shared. And we very much hope this is the start of the conversation, and that we have many more opportunities to celebrate the work that you're doing and collaborate as we move forward. So on behalf of the whole UICC team, thank you very much. And a final thanks also to the Clean Air Fund for their funding that made all of this possible. Have a wonderful morning, afternoon, or evening, wherever you are. And thank you very much, everyone.